The following program was produced by an independent community producer. The opinions expressed do not necessarily reflect those of the ECAT staff or board of directors.
Well, hi and welcome to Purpose-Driven Aging. My name is Kathy, and today we're going to take a look at the Medicaid program. There's a lot of discussion around that right now, and it's a big piece of the insurance domain. When we teed this up a while ago, we looked at the 10 domains of positive aging and purpose-driven aging. So this one definitely is insurance, and this one definitely has people's attention. So specifically what we're going to go into is we're going to look at the three phases of Medicaid to start. Basic fundamentals, and then the expansion that happened with Obamacare or the Affordable Care Act, and then the long-term care component. And then we're going to look at the 2025 Medicaid proposals, what's going on now and what the impact is today and what it could be. And then end up with how you can respond, what's really happening and how we're all affected. With me today is Grace Dotson, and Grace is a master's level RN. She has decades of experience in leading case management departments, both regionally and in large medical centers. So welcome, Grace.
Thank you, Kathy. Good morning.
So let's just dive into it here. Medicaid. Medicaid is not Medicare. So just to set that apart, Medicare is a national program. It's run by the feds. If they make a change, it affects every state to some level. Medicaid in itself is a program that is funded by the federal and the state government, but it is managed by states. So Medicaid programs are different in every single state, and they have different names. So many of you in Massachusetts know Medicaid as Mass Health. So Medicaid, the first phase, as I like to call it, is how it got started in the 60s. And it was originally set up as a program for the poor, to provide health insurance for the poor. Long-term care wasn't even on the radar. Do you remember that?
That's right.
Yeah. And the average life expectancy at that time, any idea?
63, 64?
72, actually.
Oh, okay,
but people
okay.
still weren't eligible till they were 65.
Ah, okay.
So people weren't living 30 years on the Medicaid program. And how it's funded is what's called a FMAP, or Federal Matching Percentage Points. And what it does is each state is funded differently depending on the wealth of the state, right?
Yes.
So Massachusetts, 50% of Medicaid costs are from the feds, and 50% are from the state. So you can see it's pretty equal. And when you have other states that have a higher funding percentage, like in some of the states in the South, like Mississippi can be as high as 70 or higher, 70%, and the state does 30%. So it really depends, it's state to state, and that's been in place since the beginning. And also too, Medicaid. Medicaid covers more than just the elders, right?
Absolutely.
Do you want to?
People who have chronic illness and chronic care needs, like they need ongoing hemodialysis lifelong. And they may not have full coverage under Medicare and need that supplemental pay source, if you will, to provide care and to provide coverage.
In hospital care, right?
That's correct.
In kids?
Yes, and children, absolutely. CHIP programs, that's often
So what's a CHIP program?
For children. It's for children who have chronic illnesses, and they may have limited coverage under their private health insurance, under their parents, but they need usually high-cost medications and high-cost medical care. For example, a baby born in 2 months early into a neonatal ICU, and child may have lifelong needs.
And you know, we don't even think of the kids so much, do we, when we think of Medicaid?
Right.
We often think of Medicaid as associated with older people or elderly people especially. So Medicaid's role in long-term care, how did that evolve? Because when it was originally set up, it wasn't set up to pay for long-term care. It was set up originally to pay for institutional care for people that were poor. So you think of nursing home. The elderly went into nursing homes, but again, lived to probably 72. The life expectancy was a lot lower than it is today. Well, not a lot, because it's 78 today, so a few years. But when you think about that, when you're using insurance actuarial tables or how long someone's going to live, these programs were built based on that, and they haven't changed much since, and this is part of the problem today. So through the years, we saw people in nursing homes staying in nursing homes longer.
As residents.
And it was was it the 80s or the 90s when SNF level or subacute care was added and started to pay
90s.
For acute?
Yeah.
It was
I believe it was either the end of the 80s or early 90s, yes.
Yeah, and so what's the difference between going into a nursing home for subacute care or like an after hospitalization and rehab care or long-term care? And what's the difference in the payers, related to Medicaid?
So a subacute program, or they also called it SNF, which is a skilled nursing facility program, is quite different than a client or a patient who goes into a nursing home for long-term care as a resident. They live there. But today, it's very popular for people to move from the hospital into a SNF program or a subacute rehab program where they're going in for several weeks of care, on average 3 weeks of care, and they're getting nursing care and medications and treatments, dressing changes. For example, they're getting physical therapy and occupational therapy, but it's it's a transition from the hospital usually to get them well enough that they can return to the community and go back home. So they're not
that's
staying
the goal.
there as
the
residents.
goal is not to be a resident permanently, the goal. And that's the difference, because the payment for this type of care is your acute care insurance, whether it be a commercial product like Blue Cross Blue Shield or a Medicare product, such as Original Medicare or Medicare Advantage, that pays for this until it doesn't.
Yes.
And then if people end up having long-term care needs, which many, many do, then what's happened is it's evolved into people needing more and more of this long-term care, and there wasn't a payer for it.
That's correct.
So what happened, Medicare wasn't going to pay for it, insurance wasn't going to pay for it, so it kind of fell to Medicaid.
Yes.
And the long-term care started stretching and had a lot of holes. And then we developed, or implemented is probably a better word, home-based and community services.
Yes.
And this was done as a way to help keep people in the community. And these are programs that are offered through your local ASAPs, Aging Service Access Points, that's what it's called in Massachusetts, or your elder services that coordinate these, your PCA program, your in-home care services that you would get, maybe some of the Meals on Wheels. Just think of anything that's coordinated. And that's paid for by Medicaid.
Yes, and PCA is a personal care attendant who helps with bathing. They may actually empty your trash or cook a meal for you, which is different than a visit from a VNA, a nursing agency that is very time limited and paid for under Medicare.
Yeah, and this is the hardest thing, I think, when we're looking at Medicaid, is a program, because it not only pays for, as we originally talked about, children and adults and older people as a primary health insurer, but it also pays long-term care for people that are long-term disabled, like through these PCA programs or adult foster care programs, all underwritten by the state's Medicaid program, all designed to try and help keep people at home and out of expensive institutions. And what happens is, in order to qualify for Medicaid in any state, there's a process called spend down.
Yes.
Do you want to talk about that a little?
Sure. So, for example, somebody would benefit from staying home, and they need lifelong care on a ventilator or a respiratory machine that gives them oxygen, and they need hands-on nursing care, those aides coming into the home to help with bathing and such. And those needs are expensive, but if somebody does not qualify financially, there is an option called a spend down. So a financial counselor may sit down with, say, the parents of a child who's on a ventilator, as our example, or the family, to walk through what kind of income do you have? What kind of assets do you have? You own a home, maybe you own cars, and then maybe that person is a little bit above the line to qualify for Medicaid, but if they spend down some of that funding that they have, then they would qualify. For example, they may prepay for a burial. That's one example.
And what happens with the spend down is you have to get to a certain level to be eligible for Medicaid, both clinically. If you were in long-term care, Grace gave a good example of the person at home on a ventilator with an acute care model. In a long-term care model, someone could just have, a dementia and it's not safe alone, and they're trying to manage a person in the community. And in order to get there, they have to clinically qualify, so they have to have a certain level of disability in the long-term care. And then they have to clinically qualify, so they have to have certain, when someone comes into the home or into the nursing home or the SNF or the skill facility at discharge, this is what I did for years, and this is what people, like myself in nursing, and Grace was discharging from the hospital. Everyone's looking at what is the level of ability, what is the potential for the person to get better, is this the new normal? And then what the financial situation is, not just with money or assets or income, but also where does the person live, and what kind of resources do they have? They live alone, or do they live with others? So all of this falls into, and you can see how Medicaid programs at the state level, it's the largest budget item for some states.
And in addition, sometimes people need transportation. They're wheelchair bound and they need a wheelchair van, and they need help with paying for that. So Medicaid may cover that if the person qualifies, to get them back and forth to doctor visits and such.
Yes. And one of the things that has happened with the nursing home industry and the long-term care industry is they used to have a better payer mix than they do now. Most nursing homes, Medicaid is their primary payer. And Medicaid pays a rate below cost of care. That's a whole other discussion. But the reality is that, nursing homes used to have private insurance, they used to have different private pay, and they also had Medicaid, so they were able to cost shift around within the organization to stay afloat. And now there are different models out there that are more attractive than nursing homes to take a lot of that private pay away. And by the time somebody's ready to go into a nursing home, they're pretty much impoverished. So the third phase of Medicaid that we're looking at is the expansion. The expansion is what's called the Affordable Care Act, or Obamacare. And what that did is it looked at taking states across the country, every state was going to expand its Medicaid program to increase the federal poverty level from what that state's federal poverty level was. The feds put it in there and the states adjust to it, but it would raise up to 138% of the federal poverty level. I don't want to throw a lot of numbers at you, but it's about $20,000 to $25,000 a year for two people, which was huge because so many people fell through the cracks. They weren't eligible for Medicaid, private insurance was too tough, and their employers didn't provide for it. So back in 2014, I actually published a book called Too High a Price that actually outlined all of what Obamacare covers in easy to read language. So it's available online if anybody's interested. Some of it right now is not applicable. But what happened is in 2012, the Supreme Court said, I don't think so. We're not going to let every state, you can't be mandated to expand your Medicaid program, because they thought it was a tax and there was a whole bunch of other stuff in there. So what happens to people now that, might be eligible for Medicaid expansion and the state doesn't expand? because you had this in South Carolina, didn't expand, right?
Well, there was a demonstration project that CMS, which at the federal level provided funding for this project, and that was a year-long project working with the governor, the Department of Health, hospital representation, visiting nurse representation, transportation, medical transportation providers, social workers, nurses, a big mix of people came together to meet and build a program that was innovative. There was structure provided by CMS, the Centers for Medicare and Medicaid, and look at what is it we can afford to provide to residents who are duly eligible, for example. They have Medicare that they qualify for, and maybe they would apply for Medicaid with additional services and some funding, and building out programs including transportation and processes such as social workers calling the doctor's office when the patient arrives to the ED for the third, which is the emergency department in the hospital, for the third time in a week, looking at data, overutilizers, people who they're falling through the cracks because they don't have a doctor, for example, they don't have a pay source, but they're coming to the hospital over and over and over again, and they really need care, but it's not emergency care. And building programs and connections that happen as the patient arrives, or even better, preparing in advance to avoid overutilization of the emergency department.
And as you can see in the Medicaid program, this is where it gets muddy because the feds can do some of it, but they can't implement in every state the same way. That's overreaching because every state controls its own Medicaid. And this is why, if you live in Florida in the winter and you live in Massachusetts in the summer, and you may be looking at two different ways of administering programs. I know I've talked to some people that are, I think I want to move to Florida. And I was like, ooh, here are a couple of things to think about if you're going to make that your primary residence. So as we look at these three phases of Medicaid, the original that was started, way back in 50s, is it 60 years ago? Almost 60 years ago now. And how it started out to be just basic health insurance for the poor, expanded into the long-term care arena, continues to expand and expand. And then when Obamacare, or the Affordable Care Act, came in, it also added another expansion. So with all of this, we can see the need is growing, but we don't have, in the government, don't get me started, but doesn't figure out how to pay for things before we expand things, before we do things. And this is the problem we're into now. And this is not a political discussion by any means, but politics is very involved, especially when you're looking at public programs like veterans benefits, Medicaid, and Medicare. So what we're going to do at this point is we're going to shift into talking about what's going on now, and then kind of try to look ahead a little bit, because for all intents and purposes, and all the discussion and the hype and the fear-mongering, Medicaid has not changed anywhere yet, unless it's done at a specific state level. But there is preparation looking ahead to go for cuts. So I'd like to talk a little bit about, you might have heard the term block grants.
Yes.
And when we talked about the FMAP, or the percentage, Massachusetts has 50% by the feds, 50%. Now there's a difference between percent and fixed cost. So if the Medicaid costs are going up with all this expansion, right, then the feds are matching that 50% no matter how high it goes. Now when you start talking about block grants, you're talking about fixed cost. So it'd be, say, $100 per resident per month or whatever. There'd be and no matter what the need is, if we have a pandemic or some kind of flood or emergency, or the population grows and the need grows, it'd still be that fixed amount. So what does that do? It puts the onus for the cost management, full cost management, back on the states.
Absolutely. And I wanted to kind of circle back. You were talking about variation between states and Medicaid programs. And it is really the operations and building out a program, innovative programs that will meet the needs, but also constrain cost, if you will, because you have a finite amount of money to spend. But what's interesting is, back to the state of South Carolina, what the group decided to do was kind of divide up into 3 regions, if you will. You had the low country out by the islands and the coast, and then you had the middle of the state with Columbia and the capital area, and then you had the upstate with Greenville and Spartanburg and all the way out, including Clemson and Anderson. So each region, if you will, had unique needs and kind of unique populations, if you will, as far as what's
similar
available.
To Mass
what's
with
available.
Western. So when you did that, yes. So that does have relevant. Go ahead.
So with that, we were able to, for example, create a call center that patients or clients in the community or families could call, and it was statewide, and that worked. But then there were certain things such as ambulance transportation, wheelchair vans, transportation. You could have a statewide program, but then you needed to regionalize because there were certain factors that played into, how available those wheelchair vans would be, which are always in high demand.
Yes.
And also the partnerships and hospitals having partnerships or knowing, the providing agencies and vendors in the community. Very important.
Way back when, I forget the politician's name, said, all healthcare is local and all politics are local. Everything is local. And, when it comes to, cuts or changes to how Medicaid is reimbursed at the state level, it is going to have a ripple effect into every single state. And every single area is going to, then, as Grace was saying, is going to respond differently. Your urban areas are going to look different than your remote areas, like in the Western Mass versus the Boston area, versus the Valley area, versus Cape Cod.
Yes.
And what are the resources there and what happens and what decisions do states make? So these are all the things people are grappling with now. Nothing has been determined. But the discussions are moving forward about going to block grants, going to work requirements, and other things around Medicaid. So we bring this up to kind of help you get more aware of what is actually happening right now and what those ripple effects can be. And let's go back to long-term care, okay? We were talking about the nursing home industry, those community-based services. What's going to happen if we do lock in or take the going from a percentage mapping for the states to a fixed cost for the states? So this is going to have strain on every single healthcare provider, for your physician who accepts Medicaid,
Yes.
to the hospital, to the ED when you show up and you have Medicaid, to whether you're eligible or not. What will happen to the eligibility criteria? So what are your thoughts on, the block grants and its impact on long-term care, especially? I mean, the hospitals get, with your discharges. I mean, that's a nightmare, right?
It is. So there's a patient flow is what we call that in the hospital setting. And it starts with the patient coming in from the community to the emergency department in the hospital. And there are regulations and laws around treatment and assessing a patient who arrives to the ED. You can't just turn them away. And you don't, in the hospital setting, you don't treat people differently because they don't have insurance or they have Medicaid or they have Medicare. But what happens at times is you get a big influx of patients who they're not connected in the community. They may not have a primary care provider or somebody to turn to. So they do come to the emergency department. They know they have to be seen, okay? And so you may have an ED that's over capacity, if you will, and they're calling upstairs and there's a whole department working on patient flow along with the people doing discharge planning and case management. And you're looking at an outlet for the patients who are upstairs in a bed and maybe they're close to being discharged. And okay, what are the alternatives for these patients? But sometimes that gets blocked up for that patient's discharge because of their pay source. they have a managed care plan. You have to find an in-network agency or facility for them, or maybe their pay source is not attractive to facilities.
You know, you brought up an interesting point about Medicaid, because Medicaid too has managed care.
Yes.
You know, it's relatively new in terms of its inception. I think it's 20 years or something now that it's been in effect, or maybe a little bit longer. But managed care does get involved with Medicaid.
Yes.
And one of the things that you mentioned that with Medicaid are the health centers and the physicians in the community. So how does that work for people who, are, they need long-term care, but they also need acute care? And, that medical stuff versus, my disability, they work together when you're a person, but they don't always work together when you're trying to navigate the system.
Exactly. And so in the hospital, there have been programs where we're working to map that connection between, the community caseworker, if you will, calling and talking with the acute care case manager. It's a bit more challenging to get hold of the doctor in the hospital setting.
Yeah.
And really sharing data on a medical record and having access to say, oh, okay, let's see, this patient, maybe they don't have strong support at home. And that's another thing we are going to see is more burden on caregivers and patients' families to provide more hands-on care or sooner than they expected
and
in the community.
They're already frying, frayed and, So a couple of things. One, what happens to someone who shows up in the emergency room? Either they're sent from a facility and or they're evicted, or they're otherwise the family, and this happens often. It did in my career when I was running a practice, and the families just can't do it anymore.
Yes.
So they go to the ER and they're like, I don't know what to do, but they're not really sick. They just need to have a lot of care. What happens with them?
Well, we in the hospital setting, we'll have social workers and case managers who work fairly closely with the patient and the families, and sometimes the patient's not able to participate. We're working with the family, with the caregivers, and maybe we need to put some additional services in place and really hear the voice of the home care agency that's been in there into the home or the facility and what's not working. And maybe we make a few changes to improve things so that they can return. But sometimes, as you said, the family says, I can't do this any longer, and they abandon the patient, if you will. And you then begin a legal process. I mean, it's kind of a last stop, but sometimes you have to go after seeking legal ramifications to protect the patient and get the care that they need, but it's a longer process.
As we were talking about, people who end up because there's nowhere for people to go.
Yes.
And this is one area that I wonder, is it going to get worse? Well, it's already tough.
Yeah.
But, and this is with today's funding. So this is why it's important to pay attention, all of us, that we're doing. And this is why Grace and I are sharing this information. But people end up in the emergency room because there's nowhere else to go.
Yes.
They might be, they think Medicare is going to pay for everything. And they may have what they think is a medical problem, which could be a cramp or something that they don't know what to do with, and they have nowhere else to go. And what happens?
So this happens frequently it's usually in the emergency department. Somebody is failing in the community and they don't have that pay source that's needed for their care. And they arrive to the emergency department. But again, as mentioned earlier, there are rules and regulation under EMTALA, emergency management. The hospital is obligated to at least do an initial screening and see if the patient has acute care needs. So they do a screening, they stabilize the patient if needed, but if they really don't have any medical needs, they don't need to be admitted and sent upstairs, if you will, to a hospital bed. So then they may sit in the emergency department. And Informally, that's called a situation where a patient is known as a boarder. And boarder meaning they're sort of on the cusp. They don't meet for hospital acute level of care. And really, they could return to the community if they had the resources for that. And
Resources, you mean like support resources?
Support. The caregivers, the personal care attendants we were talking about, or family support.
Now, don't people have to qualify for Medicaid? What if they're not
do.
Medicaid eligible and they're boarding in your ER? What are the options for them in that kind of situation?
Well, again, sometimes they're sitting for days and days and sometimes weeks, unfortunately, because the social worker and the case manager together worked to investigate. They'll contact the family or find out who has been supporting this patient in the community, and is there anything else that can be done? Maybe the patient needs rides back and forth.
Well, how do I qualify? How do they get qualified for Medicaid?
So there are financial counselors who work for the hospital, but also out in the community under elder services, and they will work with the patient if the patient's able to work with them and look at what kind of assets do they have. Do they have income on a regular basis? And maybe they have qualified for a couple of years, but they just never pursued it. Mm-hmm. And maybe they just lacked the ability to tie up those loose ends because of all the appointments and the paperwork, or maybe there are literacy problems with their ability to read the documents or follow through on direction. And so there's an intensive effort, if you will, from the hospital setting and partnering again with elder services, and there are folks who will help see if they qualify.
And this gets into the community resources, because it also, with the ASAPs, the elder services, they're used interchangeably.
Yes.
The elder services in this area are Old Colony Elder Services, Bristol Elder Services, down on the coastline elder services down on the South Coast. There are 26 or 27 throughout the state, and they're invaluable when it comes to helping people get qualified for the Medicaid program. And if you're not sure if you qualify, you can give a call and get screened to find out. Also, too, as part of estate planning with an attorney, there's usually different trusts that can be set up to qualify for Medicaid in the event of a long-term care need.
I just wanted to mention, some folks think that if they have Medicare, that they can't have both Medicare and Medicaid. They certainly can. If they qualify for Medicaid, they can have both programs in place. Medicare would be the first payer, for example, for the hospital care that they need. But when they have both programs as a funding source, then that's called dually eligible.
And dually eligible, so instead of having to buy a supplement, like a MedX or whatever most people, the Medicaid program in the state will function as that supplement. And one of the important things with Medicaid in that role is that if Medicare doesn't pay in that role, Medicaid won't pay. So, one has to follow the other. This is confusing for a lot of people. But also, too, it opens up other options such as senior care options, SCOs, and also PACE, Program of All-Inclusive Care for the Elderly. And people have to be dual eligible for that. There are private pay arrangements that can be made. We're going to talk about this in a couple of months. But I think it's important when people are sitting into the emergency room, I'm Medicare eligible.
Yes.
But I might not be eligible for Medicaid, whereas I put the two of those together, I'd have payers for my hospitalization.
Absolutely.
And maybe my rehab, where I might be able to improve my situation.
Yes.
And then be able to go home more independent, whereas now I'm kind of stuck.
Yes.
So the long-term care piece is huge when it comes to Medicaid, because it's the primary payer for long-term care services, institutional and in the community. And here's what we're going to be watching.
Yeah, I just wanted to mention, too, so we were talking about the scenario where somebody arrives to the emergency department and they don't have acute medical needs, but really maybe their issue is functional. and they need some rehab to get their strength back and really be able to function back at home with some services. And those patients may be able to go right from the emergency department into acute rehab under the Medicare benefit.
Right,
if they have Medicare.
that's true.
And
Can you explain the difference between acute rehab and subacute rehab?
Certainly. So acute rehab is a program, and it may be in a standalone facility or it may be part of a hospital as a separate unit. And an acute rehab is an intensive rehab program where the patient goes in, usually average stay is 10 days, and they're getting a full assessment by an entire team with physical therapy, occupational therapy, maybe speech therapy. For example, a patient's had a stroke, they need to work on swallowing and their
And they
speech.
have to be able to do so much rehab a day, right?
That's correct. They need to be able to do 3 hours of therapy a day. They split that into 2 sessions in most rehabs so that the patient has some downtime to recover and have lunch and then go back, usually in the afternoon.
Because it is intensive.
It's very intensive,
Yeah.
and it's either 6 or 7 days a week. So it's a very intensive program, and people are tired when they go through this, but they do improve. They improve dramatically.
And that acute rehab is covered under the Medicare benefit.
That's right. And there's a physiatrist, which is a specialty doctor who oversees the whole program and signs off. The whole team meets once a week and they review care plans. They do special discharge planning meetings involving the family and the patient at the bedside. It's a very comprehensive and very good program, but not everybody qualifies. If they can't do the 3 hours a day.
And that's determined in the hospital before the person's transferred.
Yes.
Yeah. So one of the things that we wanted to look at here too is, yes, if Medicaid goes to block grants, or if there are other changes to the state's Medicaid program, it's not just about Medicaid. There is a ripple effect throughout the entire industry that will happen with these changes that will affect all of us, including you and me.
Yes.
And we just want to spend a little bit of time talking about what some of those changes could be. So Grace brought up the dual eligibles, but we also have funding for Medicare, whether or not you're not Medicaid eligible, it's still funded by the same dollars, which help with the cost sharing. So it helps people these cost-saving programs administered by the state. And some of them help pay the Part B premium, which is $185. And some of them also help pay the deductibles,
Yes.
for people who aren't quite able to afford a supplement and aren't quite eligible for Medicaid. And also, too, can you talk about how these cost shifting and these effects would hit private insurance in the payers, in the providers? If Medicaid, will they stop seeing Medicaid patients? What will happen?
Well, that is a risk. In the community, it's very different than in the hospital setting. Again, the hospital has laws and regulations about emergency medical treatment stabilization. So everybody is treated the same as they arrive, and cares, without the payer. You're sort of payer blind, if you will.
Yeah.
But then in the community, providers, meaning doctors and programs.
Where most of the care happens.
Yes,
yeah.
They can absolutely say, you know what, we're not taking Medicaid patients, or we're only taking private insurance, or we're only, so that can happen. And also, when Medicaid makes changes to the program and the funding, and what's covered, what's not covered, for example.
Right.
Oftentimes, these private insurances, the big ones are like Aetna, Blue Cross, et cetera, they fall in line with, okay, we're going to follow those same guidelines.
Yeah, that happens a lot. Mm-hmm. Yeah. And what happens, explain how cost shifting works within institutional settings when one payer doesn't quite pay for the actual cost of care, and how that's pushed on to other payers.
I'm not sure I can really delve into that too much.
So one of the things that is if Medicaid starts lowering its rate to providers.
Yes.
Which has been happening. It's been slowly going in, because as we all know, costs of care are going up and up and up,
Yes.
and the insurances don't keep up.
Yes.
So institutions such as subacute, physicians, hospitals, start shifting some of their operating costs onto other insurers, like the
correct.
private insurers.
So those are contracts. Those are usually very big contracts. For
Right.
example, in the Capital District of New York, there's Capital District Physicians Health Plan, CDPHP is a big payer. And those contracts are, they sit at the table and they hammer out all the details. And as the cost of care goes up,
Right.
the hospital may be asking for this and the payer may be
asking for that.
Exactly.
Yeah.
So there's a lot of back and forth and back and forth. Sometimes contracts are broken, and that means that provider, that hospital system is not in network, which means they still have to, if the patient arrives in the emergency room, they still have to stabilize them, but they may transfer them out
Right.
to a network facility that is in contract. So there's a lot of back and forth and negotiation.
And then
with
what that does is, for those of us or others that have private insurance through your employer,
Yes.
or you may get it, with a group plan. Like when I ran a private practice, I joined a co-op from a business to get health insurance. We see our premiums start to go up.
Absolutely.
So this is a ripple effect. When one insurer starts paying below, either people are cut off, or they'll lower the requirements. So instead of being 100% of the federal poverty level, it may go lower and lower.
Yes.
With the Obamacare or the expansion that we talked about, when that was originally done, the federal government pays 90% of that expansion and has since 2020. If that is going to go away, which there is strong probability of that, then who's going to pick up that 90%? The reality is states cannot afford to do this.
No.
Any state cannot afford to do this. Some are a little bit more generous. Massachusetts is one of them that puts a lot more. As a matter of fact, the Obamacare model was kind of mirrored off of the state of Massachusetts.
Yes.
And Massachusetts has been expanding and playing with its Medicaid program for years. But as Grace mentioned, other states, such as South Carolina, to mention one, didn't. And they have much stricter requirements. So it's good. The ripple effect is it gets to all of us with higher premiums. And then another ripple effect is the downstream providers, your rehabs and your nursing homes start to close.
Yes.
Can you talk about what you've seen with this?
And for example, in New York, I can remember there was a statewide look at how many facilities there were and how many beds are really needed for hospitals and rehabs. And that was back in probably 2005. There were hospitals that closed. There were hospitals right across the street from one another in New York City, for example. And so it was determined that really there were too many beds available for patients. There have been nursing homes or skilled nursing facilities, if you will, that have closed because maybe they have absorbed too much cost and the costs exceed what they're able to
And that's
pay.
what they do. We've all read the studies and everything about, cost reports. And everyone has cost reports. So where is the money going? And the thing is a lot of the money with Medicaid, even if it all went to care for patients, the acuity or the sickness of a lot of people in nursing homes now is much higher. So the resources needed are greater.
That's true.
And the Medicaid programs in the state don't keep pace with this increasing cost. So either they have to find it somewhere else, they have to cut, or they close.
Yes.
And we're seeing a lot. I just read this morning, 2 more hospitals actually in Pennsylvania.
Well, you bring up a good point about like that transition from the hospital out to a skilled nursing facility. Years ago, if a patient needed to get therapy, IV therapy, an IV in the arm, for example, with antibiotics to treat an infection, they stayed in the hospital, sometimes 10 days, 2 weeks. Not today. They would transition either to home to do that. If they don't have the support to be able to do that at home or they can't learn, they may go to a subacute facility program in a nursing home where they're getting that therapy, maybe it's 2 weeks or such, but some of the medications are quite costly.
Oh, yeah.
And so as nursing home screeners look at patients that are referred to them, they're also looking at the cost of care.
Yeah.
Is there a very expensive device called a wound vac? Is there, to draw fluids away from an extensive wound, is there a very expensive medication, a chemo medication, for example? And that factors into the final determination to accept the patient.
And it does. So that's a good point. So nursing homes or long-term care facilities in general don't have to accept a patient.
That's correct.
They can refuse if they're not able to provide the level of care.
That's correct.
Either clinically or financially that the patient requires.
That's correct.
And this is an interesting, transition here that, with everything going on, and this is what we know today. And again, we're keeping our finger on the pulse of what's going on, as it affects all of us, both as consumers, as patients, and as practitioners. But one of the things that we want to start to talk about now is what can you do? What are the resources that are there, and let's package them up. Because whether you're getting Medicaid and it's for your child or it's for yourself as a young adult or a family, or maybe long-term care for yourself or for a family member, or maybe you're caught up in the Obamacare expansion, you're wondering if you're going to be able to have health insurance, what happens? So I wanted to kind of shift back to what do people do when you have Medicaid, you don't have Medicaid, or you're underinsured, or you're not insured at all because you just cannot afford it and you're not eligible for Medicaid. Sounds familiar?
Yes, yes.
So one of the things that I'd like to talk about just for a few minutes is EMTALA, or how it's one of the things where people will say, why are the ERs so crowded? Why does everybody go to the emergency, and why do I have to wait hours? And you mentioned you have boarders that are there for days, if not weeks.
If not weeks, that's correct.
So can you explain the EMTALA and how that came and what it means and how we got to where we are from?
So there's quite a bit under the umbrella and the regulations and laws around EMTALA, but it's really for patients who are arriving to the hospital, it's to protect them. For example, a mother in labor who is in crisis, about to give birth, what they're trying to protect and avoid is having that mother bounced out and sent by ambulance. Oh, we can't accept that patient. We're too full in our emergency department. Send them to a rural hospital 40 miles away, which could put the mother and the baby at risk, for example. Or somebody arrives to the emergency department, they are having chest pain, but they need to be treated. They need to be assessed by the physicians, by the care team to see what their needs are and have some tests done to evaluate, treat them if needed, and make a decision. Maybe they need to be admitted upstairs, or maybe they could be treated in the emergency department and return. But it's to avoid sending people away back in the community when they're at risk, maybe to die.
So is a hospital required to evaluate a patient before they can make that decision?
Yes.
So that's required?
Yes.
So it's like the big default?
It is. It is. Evaluate and treat, yes.
So no matter whether I'm insured, uninsured, or whatever, I have to be seen?
Yes, yes.
And then the decision is made from there?
That's correct. That's correct.
And then, as we were talking earlier, then if somebody may be eligible, it might be a way to bring in the state or some community resources to help level or enroll the person in the state's Medicaid. So what about the hospital financial, what is it called? The financial department, the patient assistance, what's the name? I'm not sure.
Patient assistance.
Okay.
It's called different things in different hospitals.
So how does
Years
that?
ago, it used to be the business office, but
Oh, really?
these staff are usually very well versed in working with a large number of patients and families, and they have connections into the community with elder services, for example, and they know how to work all the process, the paperwork and such, and what information needs to be gathered and evaluated to see if the patient is eligible.
Do I have to go to the ER to get access to that service?
No, actually, it's better to have that service, pursue it online or with somebody at elder services in advance of an emergency situation. Much better. In the emergency department, if you will, it's kind of a chaotic crisis environment and a period of crisis. So that's not the best time, and you may not have all the documents you need as a patient to provide information to the financial counselor. I mean, you could bring it back, but sometimes there's a handoff between the hospital, financial counselor, and the community provider or
So
community.
Can we shift for a
counselor.
minute? Because I know you've worked with community health centers.
Yes.
So how would that, because ideally, if someone could get on Medicaid, or is on Medicaid or is eligible and not on Medicaid, these are great resources.
Absolutely.
What's the difference between using a community health center for primary care versus using the ER for primary care?
Much better in a community health center. For example, these are staffed by dedicated physicians, nurse practitioners. They're usually case managers, social workers. There are cultural factors too. You may be in an urban area with a lot of people from another culture, and
Like Haitian or
absolutely.
Portuguese.
So they take that all into
Yeah.
account with the staffing and with translation services and interpreter services, and how they are able to kind of navigate the patient in their own community. So these services often look at the softer side of the medical needs of the patient, make sure, again, do
Do
they
they
have
offer the
transportation?
consistency, the health center? Do they serve as a primary care
They can.
resource for the
They
patients?
can. Yeah, there are physicians who they're dedicated to providing primary care to patients who are usually they're lower income patients.
But they're
and
Medicaid eligible.
That's
A lot of them are on Medicaid.
That's correct. Or free care. They call it charity care. They're
Okay,
providing
what's the
that.
difference then? What's free care?
So, for example, they don't quite qualify for Medicaid, but they're sort of living on the edge, if you will, financially, and they have
Say
needs.
diabetes that's not well
And they're
controlled.
not taking care, and they need wound care, and they need medications. So free care, for example, in a clinic, and hospitals provide free care too for folks like this. So they would help connect them and get them medications. There are usually pharmacies connected or on site with these community health care centers, and they may be looking at generic, low-cost medications, but getting them on to something and then following up, either through pre-scheduled appointments or calling or telehealth, where they put a monitor into the home to check on a person, maybe check their blood pressure, sending somebody into the home to open the cabinets, with the patient there. But look, what is it that they're eating? Maybe they're eating high salt soups and gravies and such, but they really shouldn't be.
So a lot of the long-term care or community services are also social services.
Absolutely.
And not really medical needs.
Yes.
That people will have. Well, this has been great, Grace. Thanks. I think we've covered a lot.
We have.
And it's not easy. It's confusing. But to sum up, I think your resources that are available in the community are your local elder services if you're an older person, or in your community what may be available. I know there are also councils of aging. There are many programs that exist for people that are 55 and older.
Yes.
You don't have to be an elder. And the place to start would be to make a call to the Council on Aging, and they can always redirect you. always, if you have a medical problem or if you think you have a severe medical problem and you don't have immediate access, then the emergency room is the right decision to make. So thank you, Grace, for taking time out of your day to come.
Thank you.
And thank you for spending some time with us. I just wanted to sum up what we covered. We looked at the three phases of Medicaid. We looked at basically how it started out, how it expanded, and how it grew into long-term care. And then we looked at the 2025, the year we're in right now, in all the hype that's going on, is to just try to shut off your TV and not listen to it, because nothing's been decided yet. It's still very much in the mix, and it will affect all of us, so we're all paying attention. And then what you can do, what you can do and how to reach out. And don't be afraid to reach out and ask for help, because it is there. And whatever changes are going to come, there's going to be shifts in the way we all do business. And some of us are trying to get ahead of that curve right now. But for purpose-driven aging, I'd like to thank you. Remember that aging is a journey. And I appreciate your time today. And have a great spring.